There we go. Right. And we're 3 o'clock on the dot, so let's go straight into it. Welcome, everybody. Another Wednesday, another Philotimo webinar. A little bit of an intro as we start off. We are recording the session so we can make it available for us on our YouTube channel. So introductions, my name is EVY MICHALOPOULOS. I am the founder and the CEO of the Mahi Philotimo Cancer Project. Joining me today, John Komenos, also co-founder and director. Joining us on screen, I see Desh is there as well. And Nicole and Raquel, thank you so much for joining. And today we have an amazing special guest, and I'm so blessed and privileged to be able to share this webinar and this chat today with an amazing individual that has such an amazing story. And I'm sure Dr. Pillay is going to give us a bit of a brief as to what she does, but we're chatting about a very interesting topic today, John. Adolescents and young adults with cancer. And this is something that's so relevant and up and coming because we are seeing so many younger patients being diagnosed, and with a focus on Philotimo Kids Club, which is another addition to our project, John, we want to also try and emphasize and create a lot more awareness around this, especially for young children, young adolescents as well. But enough about me and our intros. I'm going to hand over to our guest today. Thank you so much, Dr. Pillay. If I can hand over for a little brief introduction as to who you are, where you're from, and we're going to also be sharing a presentation. So please, if you have any questions, there's a little chat box at the bottom. You can note some questions down. Alternatively, please raise your hand during the presentation and we can answer some questions. And other than that, at the end, we'll do some Q&As and have a general chat. But over to you, Dr. Pillay. Thank you so much.
Thank you for having me. And I guess first thing is well done on the marathon. It was fantastic.
Thank you.
Thank you very much.
It was hard work. After the event, we felt like we'd run 115 kilometers.
I am just screen sharing here.
There we go.
All right. Are you able to just see the presentation? Good. Okay, there we go. Okay. So let's see if I get this right. Okay, so just a little bit about me. So, you know, you've read the bio, and it's always strange saying a little bit about you, but I am from Johannesburg and lived here in those dusty streets, in those little old townships just beyond Soweto. And growing up, it was very hard not to be aware of my surroundings, right? And to look at and understand social injustice. And so growing up, that really colored everything that I did. And I always knew that I wanted to do medicine. And it was a very long, sort of drawn out way to get there. But eventually, just after graduating, so I was a much older student. I was 30 when I finished medicine. And then I did, internship. And I said, okay, I'm going to do just 6 months with Doctors Without Borders. I'll come back and specialize. And next thing you knew, I fell in love. 10 years later, I came back to South Africa. I think that's a big part of fundamentally who I am, because it's, it's beyond this world, right? What we know. But also because it just makes you remember to think about someone else. And it was rewarding, but essentially, helped me figure out how access for those who don't have it was my responsibility to be a part of it. And then I came back, and of course, back in the days, which is really important to the topic today, was we were just seeing patients with HIV die. We didn't have drugs. We were frustrated. And eventually what happened was, you know, we took to the streets to demand treatment, but we did it with a scientific rigor. And South Africa, as you know, is at the forefront of that battle. So I spend a lot of my time doing infectious disease, HIV, but rural health advocacy was a big part of also my, I guess, my genetic makeup. And so I did that. And then, of course, you get to the ripe old age of 42. And I thought, well, where do I want to be in 10 years' time? And where do I need to be in 10 years' time? And that was essentially looking back at HIV, where I knew oncology was, you know, was that place, because essentially it was invisible. That was clear to me. When I was on the continent, it wasn't even in my idea that it was a diagnosis I could have considered. And I think I felt a bit embarrassed because we sort of, you know, especially with malaria, it's HIV or TB or something like that. And so that's where I got to a point of going, okay. And now I'm just so excited, out my skin excited about oncology and what it means today, because I think even I'm surprised by the technological advancements that we have seen in it. So during this time working, for some weird reason, I found myself with patients generally who were pregnant that might have presented with cancer, so this younger female, and I found it fascinating because it was so fraught with difficulty. But I think because of it, this younger woman was just a lot more present to me because of, all our cancer patients are older patients, right?
Yeah.
And I realized, again, just speaking to them, because somehow I think I was spending more time with them than I would with maybe a 70-year-old talking, right? Was realizing there was something that resonated with me, which was, you know, like life's hard and just don't know, they just didn't know where they were. And the effect was beyond just, okay, you know, you've got cancer and I've got to take treatment. And so that's where my interest came up with young adults. And today I just want to talk about why I think it is unique. So we'll go through some numbers, types of cancers, a bit about the usual prevention and treatment. Okay. So there's been a lot of controversy and contention actually about what is a young adult, what is an adolescent. And if you look at this, you sort of go, well, you know, a 40-year-old and a 20-year-old. So what is this young adult? And there's a bit of an agreement that adolescent will be a 15 to 19-year-old, but I sort of thought the young adult I'm going to focus on around the 20 to 39-year-old. And one is because physiologically they've passed puberty, right? But they're not yet old adults where the hormonal decline has changed or where they get chronic health conditions. So it's this in-between physiological. And what's common though, from a 20 to 40-year-old is that you have common psychosocial issues. You've the fragility, your economic independence. And yet we also recognize the difference in this 20 to 39-year-old group is that they are just different from a child. They're not a child and they're not an old person, right? And so this is the data that we have from South Africa. Latest is 2017 that we've managed to get. The data in South Africa is a bit, you know, difficult, but you can see here in that year, out of 82,000 patients who were diagnosed that year, the 20 to 39-year-old group. so around 10%, right? But I mean, quickly you can go over and you can see the sort of numbers, right? You're looking at 55 to 75, where you've got these 10,000 per groups, right? Per group, and that's where we expect them a little bit. But I mean, 8,000 is quite significant as well, right? And so you've got 8,000 and you've got already 10,000 who are 60 to 65. So although these numbers are really lower, the reason why I think it's important is because premature illness and death in a 20 to 40-year-old age group has effects that are significant on society. And as we talk about, you essentially have all these breadwinners, which are just disappearing. And in fact, I think the lessons we learned from HIV, because of those resounding effects that happened around those adults, right? With childless households or grandparents having to look after those kids. So there's a lot of things that resonate a little bit there. Interestingly, the recent data from global studies have found that it's also around 6.8% of all cancers would be in this age group. But even internationally, they have said it's very likely to be underestimated. Now, from that data, the young adults are not all the same. And that's why we talked about this, why is it such a wide age range from 20 to 39? And here we can see that over 30, it's where the majority of those young adult cancers are happening, which kind of makes sense that as you grow older, that there is a little bit more chance that you're going to have these genetic effects, right? I'm just looking here to give you a sense specifically with women, okay, with the young females. And, bit difficult slide, but you'll get the point about if you looked at just breast and cervix at the bottom. So the green and brown. And you can see from 20 to 40. Those are the two major, the majority of the cancers that you'll see in females, young adults, and you can see over the age that it does increase, right? So there's a little bit of a trend there. Interestingly, quite significant number and quite consistent of skin cancers. And the suspicion is that's largely driven by private healthcare data, right? What we see in the, I'm not sure if you can see my mouse. Can you?
Yeah, we can.
So this weird gray thing here, surprisingly for me, was colon. So I was a little bit surprised, but it makes you, sort of go, wait a minute. Again, colon cancer, we just don't think of it as something that a young adult's going to get, right? And hematology is interesting because generally leukemias you would see in the younger age group. But what you see, this trend is lymphomas. Okay. So when we talk about the causes in young adults, right now, what we can say is we just don't know what makes it very different. But so there's very, similarities with older adults in terms of causes. Typically with younger, it's a lot more to do with viral infections, your genetic predisposition, that means your family history, chemical carcinogens. Smoking is still quite, I think, a significant cause. And so, which means if we know a little bit about it, can we prevent it? And today, the most, what shall we say, phenomenal thing that we have for prevention is your and screening, let's talk together a little bit, is about pap smear testing.
Yeah.
It is so interesting because it is significant. You can do it and you can make a difference. Family history. That seems so obvious, right? But when you have a family history and you should go for genetic screening, I'm pretty sure a lot of people would just be too scared to.
Yeah.
So even though we say we know it is significant, I can tell you now of people I know who are just too scared to screen, even though it's a significant family history. And then there's congenital abnormalities. So for example, you could see maybe there's undescended testes we know might be a risk factor for testicular cancers. For viruses, HIV, as we know, is related to cervix, non-Hodgkin's lymphoma, Kaposi sarcomas you see quite often. And then those who were treated with chemotherapy and radiation when they were kids, we should have a high suspicion in terms of watching out for those patients, right? Interestingly, the International Agency for Research on Cancer has now recently put classified exposure to ultraviolet radiation from sun tanning beds as a significant risk factor for young adults to get melanomas. Next one. So what is the problem is that we find young adults, actually when they come, it's quite late. Young adults are not presenting with a very, small breast mass, right? And one is because they do delay seeking medical help. I think GPs are less familiar with the sense of cancers in young adults, the signs and symptoms that they might be worried about. And usually it is just dismissed as a hangover, fatigue, you've got exam stress, you can't concentrate or, and life's hard, girlfriend, boyfriend, or whatever it is, right? And I think in general, they might just not be taken seriously when you're coming sort of a hypochondriac kind of dismissal, right? In the UK, they just found that a third of young adults who presented with their cancers were done so in the emergency room and had 4 GP visits before that they were found to have cancer. So it's it's an important concept, right? The usual thing, in fact, someone told me this week, and she said, but I was just too young to get breast cancer. It's a myth. And she really just went, why me? It doesn't make sense. I don't smoke, I don't drink, nobody in my family has it. Classic, right? This whole infographic. Just spoke to what she told me, in fact, this week. So what do we know about treatment and why that's unique amongst young adults is that because the young adults have such biologically distinct tumors, it means our treatment's going to be very different. We see that young adults respond differently, and tolerance for chemo is different, sometimes favorably and sometimes unfavorably. It's not always, but it's important because if it's unfavorable, the response, it could affect the outcome. So both of those things are actually quite interesting and very different in young adults specifically. We know that treatment for young adults in different countries is different, so which means we don't know enough, right? There's no clinical trials. The regimens are different. So can we say this is the right treatment for a young adult? Should they be getting something different? This person I spoke to who was diagnosed in her 30s with breast cancer this week, we talked about chemo, and there was a particular oncology center where it was dark and brown chairs, and there was another one she had visited with a friend, which was bright, and the way the room looked and the fact that it was scheduled where there were other young people and they were laughing, and what a difference it made to her being able to tolerate chemo, right? So it's not even just physiological.
Yeah.
And in terms of when we look globally, can you imagine that in France, for 67 million, like South Africa, There are 13 dedicated, just adolescent young adult centers, because they have said it is different. You're going to go to a center where everything will be based on the fact that you are a young adult, so you won't be treated the same. Now, this bit's a little bit tricky, and I'm almost literally at the end, because this is where we get into trouble with young adults. So they have physical changes. Your body is changing from puberty. You are developing your self-image, your identity, your relationships, your sexuality, intimacy, yes, and independence. So you have risk-taking. You know, when you're 21, you can be impulsive. You're testing boundaries about what's going on. Whereas once you start to get to your late 30s, you now all of a sudden have a newfound drive to plan for your future. Whereas a 21-year-old isn't, right? And so there's this sort of competition then that happens individually within this young adult that I don't think when you're sitting in a consultation room with an oncologist for 30 minutes or an hour, if you're lucky, you're going to be able to figure out which one of those you are. Interestingly, disclosure came up recently about Instagram, where someone I met said she could disclose on Instagram, but not physically next to her family. She found it difficult. It's interesting that sort of Instagram culture, which I'm not even on Instagram, which means I don't know it, which means I don't understand it as an oncologist, right? And at the same time, there's been this idea that, you know, with disclosure and public speaking, a lot of young people feel like a prop for fundraising. They feel like they have difficult relationships with their caregivers all of a sudden, because now they are treated a bit like children and they do have caregivers. So all of a sudden, this disclosure and issues about who will I tell changes. Many are worried about exams. That's enough for me on any given day to be worried about it. And so someone going under chemo is still thinking about an exam, right? Work factors. So someone said to me, someone at work randomly said, "Oh, you've lost so much weight." You know, just a simple thing like thinking, who do you tell? What are my side effects at work? What are the things I'm entitled to in terms of sick leave? Raising children is never easy, but I mean, raising children while dealing with cancer can be truly overwhelming. Yeah. Because essentially you're concerned about your child's future. And a friend of mine, patient who was pregnant with lymphoma, she said when she was diagnosed, her main thing was, oh my God, am I going to see my child? Will I be around, you know? And guess what? All these years later, she's in a custody battle. And she says, you know, can you imagine? I'm here all these years later. Back then I worried about whether I would be alive, you know, to see my child. And here I am actually dealing with the fact that I am a young adult who is now having a different reality. And then I think, you know, in some way there's this transition from being a patient to eventually, oh, I'm a survivor. And for me, I think a little bit that cancer is never really over, whether you're a survivor or you have metastatic disease. I think that's maybe a talk for another day, but I'm sort of not so keen on the terminology of survivor, as I said, because it kind of, it undermines a lot of patients who maybe have metastatic disease, as if they're not surviving every single day. And it sort of implies that people who don't survive have lost, you know, that they're losers or they didn't do as well. And so a little bit, you know, I sort of have a little bit of problems about that terminology, but I think it's still something. This is just the notes for you to keep. And lastly, is COVID. Yeah. And I think if there was ever a moment that we have a glimpse of what isolation is for a young adult with cancer, we would have it now. I don't think we could honestly empathize with what that isolation means until I think this moment, because we've all felt it in a real way, right? So what does the future hold? I don't know. I mean, there's lots of interest and attention and enthusiasm, so that's all good. And essentially, I think that means we're hoping that momentum means something, right? So that's it. A lot I rushed through. A lot of it can be a bit technical, and I could speak for hours, but I'm happy to take some questions. And
thank you. Let's see if we have some questions. Does anybody have a question for Dr. Pillay? Any hands raised? No? Everybody's still absorbing all the information. Nicole, there we go. Go ahead, Nicole.
Mute.
Yeah.
Hi, Dr. Pillay. I'm actually a navigator for Fellow Timor, and I'm a breast cancer survivor. I mean, you just said you don't like the word survivor. And I mean, I quite agree with that, because I must say, I had very early stage, low grade endocrine breast cancer, and I had a bilateral mastectomy. And I'm just on tamoxifen. I was very lucky. I avoided chemo and radiation. But I've been training as an oncologist for the past 2 years, and I've seen I work with Prof. Ben at Hill & Joseph, and I've seen some pretty hectic stuff, and just working with a lot of the patients from Fellow Timor as well. For me, I think the past few months have been quite psychologically daunting, because I've lost a few patients. We lost a very close friend out of our Fellow Timor group. And I almost have this guilt, because I've been extremely healthy. I was diagnosed in 2017, so I'm going on 4 years now. And, there's definitely that, like you're saying, between survivor and metastatic patients. And like I say, I almost feel guilty when some of the stories and some of the hard journeys that some people are facing. And, I just sort of breeze through, breeze through everything. I have had a few scares on the way, but nothing critical. So I think that is a very good subject to maybe do for another day. I don't know if any of the other Steve and Raquel would like to say anything in that regard. Yeah,
that's very true.
We could definitely do this another day, because I've already got I don't know, 6 blog posts about how words matter, labels, and the smallest things. I'll give you an example. Okay, you might not have had radiation for breast cancer, but we use the word boost, and it's a funny word. And a lot of my patients couldn't understand it. And then eventually it became a word that helped them feel optimistic. But we just use it in such a clinical term. We had no sense that it mattered to somebody, right? I'm very, very, very aware that labels are dangerous. Because do you want to only be known as a person living with cancer? Is that all your identity? Is it with you every single moment of your day? Some people say yes, and some people say no. Even if it is, does it matter? For me, particularly for patients with, I don't like battle words. So I don't like saying she lost the battle, or, lost the battle, or fight. It just sort of implies that somebody, so if it's okay, she's a fighter and she did well, or whatever it is, and, she fought this, and then somebody lost the battle. They don't lose, they weren't weak. It wasn't because they didn't fight hard enough, and that kind of thing about surviving is as if you got to the other end. So I'm a bit wary of using that terminology with my patients, because it does mean that, as I said, it's sort of saying, well, you didn't get through the other end. Actually, every single day is, if you've made it through today, you've survived, right?
There's
And
other
so
terms as well. There's thriver. Have you heard that one? I had to look
Sorry?
it up. Thriver.
Thrive.
Thriver. TH. Yeah,
do you
thriver.
like it? Do you
I
like
don't like it.
I think warrior is a nicer word in some ways, but yeah, I don't know. I think even with the word hope, I've read quite a few things, that, you say to someone, I hope, but even that word for me, I hope you're going to overcome when the patient's fully metastatic and, they're not, then they're not. For me, that word's also, I don't know, not great in a lot of context.
I think everybody has their own definition of what they're going through and how they do. For some people who have perhaps had a difficult life and all of a sudden they're fighting and they survive cancer, I think they can champion themselves and feel amazing about that and call themselves, a warrior or a survivor.
Yeah, exactly.
Everybody's different. And it's interesting that we started talking about this topic, because one of the things that I wanted to ask you, Doctor, was how do we approach children who have been diagnosed, particularly those that I'm not talking about infants or anything like that. I'm talking about kids that, that can understand that there's something wrong with them. How do we call them heroes? Do we call them champions? Do we even title them at all? What do you suggest we do?
I think we should ask them. 2 is, I think, if we use 1, if we try to create a dictionary, it's possible, because a dictionary does help you to get a sense that it's, it's an encyclopedia of words, right?
Yes.
And that each one will matter in a different circumstance.
Yeah.
I think there's a lot of pressure on young adults because of the way we have talked about cancer. So we've talked about cancer knowing there's this pediatric patient, right? Which is, we have all this sympathy because it's this like little cute nunus or whatever. And so there's a lot of this softness about it, this caring. Somebody who in the hospital room gets balloons and teddy bears or, all that sort of stuff, right? And then there's this young adult who's maybe treated like a child. And I'm not quite sure. I've seen it. I have one person in my mind. It was interesting. She was in an adult ward, but there was so much pink. And the question was, where should she be? Does her age define which ward she went to? It was very interesting, actually, because in the end, she said she didn't have a voice because it depended on everyone around her and she just didn't know yet. So then we expect them to know, and you don't even know who you are at 16 or something, right? So that's one thing of the way we do it, the words. And then there's the older one, which is about being independent, being strong. No, even if you're 60, you don't have to be strong. Even if you're 60, you can be treated with adoring affection, and sort of made to feel like somebody will do absolutely everything for you and will be devastated that you would have left them, you know. And so this continuum and spectrum for me is interesting, because some things might overlap, but I think we might be a little bit dangerous. And I don't like battle terminology. I personally find it difficult, because, you know, last year I had, you know, so interestingly, on the day I finished as an oncologist, my father-in-law was diagnosed with metastatic pancreatic cancer, and the day of his funeral, my mom passed away. And it was raw wave of grief and loss. And I don't think I would be as good an oncologist today if I didn't understand and feel this thing of grief and loss. And the one thing I can tell you I've learned through it, apart from all the, you know, through writing and trying to put words on it, is that, you know, words matter.
Yeah.
They matter in the weirdest of ways, because there's such an obscure sorrow. And there's an interesting thing called the Dictionary of Obscure Sorrows, because somebody tried to put a definition to words that we just can't, right?
Yeah.
And I think, to be honest, that's what I worry about, is this dictionary that we have for young adults. So I've got a lot of reflections of it. I've got lots of writings on it. One of them is I've sent for publication, but a lot of it now will come out on my posts. But I'm afraid to say things about hope. You know why? You'll know it. Because when you go to your doctor, you ask them, and you ask them about a future, your prognosis. What does it mean? How bad is it going to be? I don't know who hope matters for, because I know there are people where hope is not good for them, because they can't get through the day, because they've spent so much time hoping about, you know, surviving, you know, being a survivor, you know, getting cured. And the hope just sort of immobilizes them a little bit, because they just didn't spend today doing anything.
Yeah.
Because they've spent every minute hoping about tomorrow. And then today they forgot to maybe start their masters, even though they might never finish it, or, you know, whatever it is, right?
Then the approach.
Can I just, sorry, John?
Go ahead.
As a patient and a navigator, to you as an oncologist, I know that you're a radiation oncologist and not a medical oncologist, but I've read so much about, you know, in the cases of when a patient is towards the end and maybe they're ready to go, but the family's not, and the whole insistence on continuing treatment, or vice versa, where the patient, how do you deal with that? I mean, are you totally honest with the patient? I mean, they say a lot of oncologists almost feel guilty to actually state the truth, and that it is at the end, if a patient still desperately wants to hang on and, you know, they don't realize that death is close. Or so, I mean, how do you deal with that as an oncologist? I mean,
one, I think I've recognized, is that the person I meet at the beginning is not the same. So in the first consultation, you know, I might say, who are you? What do you want to know? Do you want to know the data and the trials? Do you want to know a bottom line? And then can you write it down? And in a week, let's talk about data, or, you know, it's going to change. That's why I think for me, words matter so much. So usually in my consultation, I do take a little bit longer to figure out words, because words will tell me a little bit about you. And then I'll know what matters to you. But I also recognize that down the line, things change. So it's a case of that I was watching some crazy medical show, right, with was it a rabbi, and he had to make a decision between having a surgery where 10% of cure, right, or not doing anything. So, I mean, 90% of dying during surgery. And the other option was go and spend a year with your family. Go be yourself, healthy, and go and spend that year. And he had to make this decision. And the first one he went with was, I'm going to go and spend a year with my family, because, you know, that's what matters. I don't need to have and think about that the 10%, I could have so much more and be okay and, you know, have a full life or whatever. And so he chose that. And then eventually he said, I had to accept that choice for him to come back and say, no, actually, I don't want to be a patient for a year. I'm going to take a risk for a surgery, and in a moment, I will know. Right? And what happened? He could basically say, from moment to moment, I'm allowed to change my mind.
Yeah.
And from moment to moment, both of those things are completely logical. Was one of them wrong? No. Because in the first minute, he wasn't willing to make a choice of his life versus his family, because that mattered. But at the next moment, he didn't want to be. So anyway, I love that, because I kind of realized that you're allowed to change your mind. And
yeah, I think that's the difficult thing, you know, for families, you know, and if the patients, you know, that quality of life maybe at the end of a metastatic journey, and you still desperately trying, you know, third, fourth, fifth line treatments. And, you know, I think as long as the patient has that hope, then I suppose the oncologist is just trying, you know, to give them that hope, you know, I mean, but, you know, sometimes when you look back and you think maybe if they'd taken the last 6 months and not gone through that, they maybe could have had a better quality of life with their families. But like you say, I think it's a totally personal choice. You know?
Yeah.
I don't know.
yeah.
Just if I can add, earlier, Nicole, you mentioned the guilt, and I definitely think that would be an awesome topic for another time. I'm in what I like to call the thick of treatment, and I already am experiencing guilt. Like sometimes I feel guilty that I'm in a blessed and very fortunate position that I have a good medical aid, that I have got access to incredible doctors. I've got such incredible support and friends and family that have been helping and spoiling me. So sometimes I feel guilty that there are so many other people that are going through this horrid cancer journey without that support and without access to these medical resources. And then I also feel guilty sometimes that I'm being so spoiled, and yet I still feel like crap, excuse the language, because that's the, you know, the end of it. So I just wanted to add to Nicole that I think guilt is an amazing topic, and I can see that when I get to further along in this journey, the guilt of how some people don't have the same prognosis can become a thing. And then also just wanted to add on what Dr. said about words. So words, one of the things I'd like to share is right at the beginning, my oncologist mentioned when I went to go see him, he said to me, you just have to do 6 TAC chemos, then we do the lumpectomy, then you do radiation, and that's your treatment plan. And I went and was like, right, this is it. I'm a type A personality. So I took the date and I put it into the calendar and I was like, this is my goal. This is what I'm working towards, da, da, da. And I finished chemo, big celebrations on the 25th of May, went back to see the oncologist to get the heads up from my bloods that, yeah, you can go for surgery. Surgery was booked. And now everything's been put on hold because the oncologist is not happy with the size of the tumor still. And I go back to chemo on Friday. And this has been a huge thing for me. And it basically goes back to that first meeting with the oncologist where it's just 6 chemos. And throughout this entire time, like it would be 1 down, 5 to go, 2 down, 4 to go. And it was this like massive mental thing. And that word just 6 is not just 6, because now back to this, and it's been a huge thing, and the words matter a lot. A lot.
It's interesting you say that. So in terms of words, I feel, to me, I would be happy to replace a little bit the idea of hope with just knowing it's all about uncertainty. And so the minute you feel the mass, you just don't know. You then have to go and get a mammogram. And then you're waiting, they're going to do a biopsy. You get an appointment. Oh, it's only in 2 days. I've spent 2 days wondering, what is this? Okay, then I get them. I have to wait for the result. What is it going to be? Okay, and then am I going to get treatment? And then it's going to be chemo. And essentially what happens, a little bit the sense of hope, is that a lot of patients present themselves wanting certainty from a doctor. I want to know I'm going to be okay. This uncertainty for me is what textures and flavors the entire thing. And that's whatever surviving means, right? Because till forever, there's never certainty.
Yes.
And so the minute that certainty is threatened or, upended, like with you were given a sense, okay, it's going to be,
Yeah.
And the minute that changed, you were derailed.
Yeah.
Why?
And the interesting thing is that so I've met with my oncologist last week, and now the new plan is to do a gem carbo on a one-on-one cycle. So do 1 cycle, see how the tumors reacted, and do a second one, and so forth. And I got home and I just said to my hubby, I'm so frustrated because like doctor can't even tell me, am I going to do like 5 of these? Am I going to do 10 of these? And he's like, okay, let me just hear you straight. He's like, Raquel, you are ticked off with him for telling you that you had 6 to do and you did 6, and now he's gone back. Now he won't tell you how many of these you've got to do, and now you ticked off with him for that. And then when he said it out loud, I was like, yes, okay,
Yeah.
point taken. But yeah. It's a frustrating journey, and uncertainty is not a great thing. And then put COVID into all of this. It's hard. It's tough.
Raquel, so you were hoping to do a lumpectomy after the first 6 Taxols, right?
And not Taxols, TAC, TAC. I did Red Devil with the mixture of other.
Yeah. But the idea was you do the chemo first, and then so the tumors are shrunk, and then there's less surgery. So yeah, that's I can understand that. Yeah, I did the same. I had all my chemos up on the fridge, and I ticked them off as I did them. And it's like 6 months. I mean, it was a long time.
Yeah.
So that's the way I climbed Kilimanjaro, and that's the way I did my chemo. It's exactly the same. Slowly, one at a time.
One at a time.
Yeah.
Yeah.
For me, I think we should just allow it to be hard. and that's why hope for me starts to get a bit, too much hope is dangerous because it doesn't allow you to just let it be hard. It's hard for you, and it's hard, right? Let it be hard. This thing about needing to be positive or, I just need to get through this and it's going to be 6, is that actually it's okay, because what I'm doing now is because I want a better outcome. I didn't need to necessarily have something certain. What I needed to have is a good outcome. And so I'm glad it was picked up that I'd rather get a smaller tumor for surgery now than having had the surgery, still found something left over or whatever it is, right? So it's a bit of saying that, but also because data, in fact, now shows that chemo first makes a big difference, something we just never knew. In the last couple of years, we've just found out about how much chemo before makes a difference. Before you could have surgery first, right? So, but yeah, I mean, it just knocks you away. Also because you're just tired. It's not even anything else except a fatigue that's bone deep. It's not tiredness, actually. It's a fatigue that's in your bones.
Yeah.
I think a good thing Prof Ben or Cal always says, is to take one step at a time and to not think too far in advance of what is going to happen is, a good thing to maybe say to patients, is just to try and focus on the now. I mean, I know that's incredibly hard when you're in that situation and you're going through all of the side effects and the psychological trauma of, and like you say, that uncertainty of not knowing, what will be later. But when I had my surgery, I almost forgot about what was happening with my pathology. I had my surgery and Prof Ben actually left the same night to go overseas. And I actually I put it totally out of my mind and I just tried to get over the surgery. And then she actually phoned me from London to give me the results. And I was like, oh, wow, I didn't even think of that. And I mean, I had brilliant results. I had, full pathological response, no spread in my lymph nodes, and a good prognosis. And when I actually think back on it, it was really, almost like I was really glad I was able to do that. I just switched off and I really didn't focus on what that pathology could be, and it definitely helped me with my surgery recovery, going forward.
Yeah. And I think also, Raquel, and you, I see you, and I always smile because I know, you always got such a beautiful smile, and you're always so positive. And Dr. Pillay, Raquel is a mommy to two little ones. Is that right, Raquel? Yeah. And also very young, So perhaps maybe as we end off the session, Dr. Pillay, something that you can give as a take-home message, not only to Raquel as a mom who's having to go through this journey and having to find the strength to motivate and keep herself strong, but also to be there for her little ones, and that age group that we were just talking about is exactly where Raquel is, the young adults, having to be strong and having to also now, be strong for the 2 little ones that are looking up to her and what's going through her mind. So maybe, Dr. Pillay, a take-home message from you to Raquel in this regard.
I think fundamentally you're a different person. And so it's hard to know who's you in that noise, right? So it's just, I think, a bit about navigating that space. So sort of saying, who am I, right? Who do I accept is part of me that's different. And that you're allowed to change your mind, for me, is the biggest one. You're allowed to be anything, happy, sad, miserable, worried, reckless. I don't care. It doesn't matter actually what it is, right? People around you, you're allowed to let them in when you want to, how much you want to. You don't have to. That's, for me, it is. If you have it prescribed, it's a bit like the tack. It's prescribed, but it can change. So if somebody prescribes anything to you, you know, you have to know it's not set in stone. And because uncertainty for me is what I think it's all about, I would embrace it. It's a bit like hope, right? If you embrace hope, it's so different than just embracing uncertainty. It's a funny space, but it's interesting for me to say to you, I would be interested to know how you embrace uncertainty versus embracing hope. It might work, it might not, I don't know. The other thing would be that, you know, you should write. And the reason why I'm saying writing is because you can talk about it later. It'll be good to write because the rest of us need to learn. And right now you're not maybe in a space to teach. But writing is a good way to have some space for you. Not therapeutically. I mean, it's just in the moment, because later you'll be able to help the rest of us. And I think lastly it would be that, you know, it's okay that it's hard, right? And that the smallest things, when they happen, you'll enjoy the good ones. You know, the smiles on their little dimples or whatever it is. But also because you're there today for them. And that's hard, I know. But if you spend too long worrying about them, you lost the actual moment you have with them. And that's a funny, funny thing. It's so funny, and I have to remind myself, going to visit my 90-year-old demented father, is that actually it's just those 10 minutes of donuts that he wanted that mattered more today than me worrying about tomorrow. Really, it's like a weird thing that you have to practice really hard. But also because, you know, you must tell us.
Yeah. Thank you. Thank you for that. Thank you, Dr. Pillay. Raquel, I hope that helps, Raquel. And yeah, it's another session so informative, and we're learning all these things, and we're getting ideas in terms of what to talk about next. And we've got some good topics that we've made notes of, and words matter and live for today. So yeah, very interesting. So if anybody else has a question for Dr. Pillay, please just let us know now. Anybody else before we close off? No? No, that's it, Dr. Pillay. I think we've given him a lot of information. Everybody's still digesting. But Dr. Pillay, please share us with your details. I am going to also put them onto the YouTube link if anybody would like to make contact with you. If you could let us know what you prefer, email, on your website, please won't you share that with us?
Great. Yes, of course. Thank you so much for having me.
Thank you. Thank you. So we will share those details with you, and your website. You can just double check if I've got it correct. It's www.treatingcancer.co.za. And email address, Dr. Pillay, I have it as reception@treatingcancer.co.za. Is that correct? Perfect. Thank you. I'm going to share those links again with the YouTube link. And once again, huge thank you to our guest speaker. I have to also mention that today's webinar was proudly sponsored by BMW Bryanston. So thanks and a huge shout out to them for supporting us and sponsoring the session today. And we're talking about kids, and we are, as we are on the topic, next week we are going to be chatting a little bit more about pediatric palliative care. And we will be joined by Lynn Kruiter from Lombano Sanctuary. So next week, Wednesday, 3 o'clock, same time, same place. We will see you all there. Last words, John, before we close off from your side.
Thanks, Dr. Pillay. A very emotional session for me, I think. I really appreciated the manner and the way you conveyed your thoughts today. It was really exceptional, and I thank you for that. And Raquel, wow, your daughter is gorgeous, and we love you guys, and strength. And I know sometimes, Dr. Pillay, don't like to use the words hope, but we believe in hope and faith, and that's what we're here for. You know, Philotimo is about giving back to those who need us the most. So Raquel, we hear anything you need. To our champions, Nicole and Steve, we love you guys. Thank you for joining us, and we look forward to seeing you again next week. Thank you again.
Thank you, everyone.
Bye.
Safe.
Bye.
Bye. Bye.